Good afternoon. My name is Lee Fleisher. I'm professor of anesthesiology and critical care at the University of Pennsylvania Perelman School of Medicine. I'm going to speak today on the Perioperative Brain Health Initiative and perioperative brain health and how that fits into the healthcare quality ecosystem. Now, I have no relevant disclosures, and the opinions today represent my own and no federal agency which I currently work for. Now, when we talk about delirium, at least in the US, it's a very large problem. 2.6 million individuals are affected by delirium, and importantly, 30 to 40% are estimated to be preventable. It's a huge cost driver, and the potential savings by preventing delirium are quite real and something that we all worldwide should focus on. The other issue is it has both short and long-term implications. In the short term, if you look at this study published in JAMA Surgery, that if you actually have a complication, we know that affects length of stay. We know that affects whether or not you go home or you go to a skilled nursing facility or other type of facility. But the presence of delirium, and particularly delirium and a complication, is almost as bad. Certainly, the presence of delirium is almost as bad as the complication, and together, huge driver of poor outcomes. Now, a number of years ago, Dan Cole, then president of the ASA, really talked about his father. And there were a number of articles, this being in the Washington Post, about the fact that after surgery, our patients had memory loss. They had brain fog. They had, at the time, postoperative cognitive dysfunction. And this really has become very widely known and described, and it can take months or potentially years for it to either improve or, in some cases, start a real negative trajectory. And Rod Eckenhoff from Penn really said we want to know this does happen, but not to be concerned because, as I said, frequently it recovers or it masks some underlying problem that individuals should be aware of as they make the decision about elective surgery. Now, there have been a number of nomenclatures. This is one of those. The idea that delirium is the short term, days after surgery, postoperative cognitive dysfunction can occur for days to years. And now we call it delayed neurocognitive recovery or a neurocognitive disorder that can last much longer. Now, the issue of delirium is an international one. And Alzheimer's and dementia brought together a number of us, really led by Sharon Inouye, one of the true leaders in this field. And we had an international drive to illuminate the problem as a really public health blueprint. And this occurred right before the pandemic. And with the pandemic and sort of the social isolation it's brought along, this has become even more important in our older adults. In fact, AARP, which is a group dedicated to the health and welfare of older individuals in the US, developed a brain health really fact sheet. And what they said is anesthesiologists can take steps to help prevent and treat delirium by working in multidisciplinary teams. They leaned into, and many of us believe that cognitive screening is critical, at least even a mini cog or something, to assess cognitive function pre-surgery. Avoided antipsychotics post-surgery. We saw that during the pandemic. particularly in the skilled nursing facilities, the nursing homes. We want to look at other pain control options, and we believe education is critical. Now, just this year, we published a special article on what we think, from an expert consensus review of key actions, really should be done. And this Delphi approach really came up with sort of the 6 things that, choosing wisely, you should do. Education and training, critical. Again, cognitive screening, as I talked about. Delirium screening postoperatively so that you can intervene, you can orient the individual quickly, and therefore reduce the delirium burden. Looking at non-pharmacologic interventions, the work of Sharon Inouye again, that you really can orient people around by just being present. Better pain control with less narcotics, and avoiding the antipsychotics and anxiolytics for delirium prevention and preventing harm. Now, I need to thank Carol Peenan, who's now the chair of the Brain Health Initiative, for her approach at USC Keck. And you could see preoperatively the clinic screening, the cognitive testing, and the appropriate patient, the geriatrician recommendations, and a pharmacy. Intra-op, really notifying both the anesthesia and the surgical service of the risk and using it to guide management. Post-op, returning cognitive aids, really orienting the patient. Protecting sleep-wake cycles, critical in these patients because a lot of the delirium occurs from disruption. Volunteer visits, that idea of non-pharmacologic intervention, nurse champion, and pharmacy alerts, and really bring them back to the normal state when they return home. Now, I do have to acknowledge last year a randomized trial to have preoperative normal daily activity or some sort of cognitive exercise intervention preoperatively. And as you can see, 97% of the patients in the control group completed the brain exercise. 23% delirium in the controls, but only 13 in patients who participated. So perhaps we can do prehabilitation on the brain, not just physical activity, and get our patients to have reduced cognitive dysfunction postoperatively. In the US, we have something called the age-friendly health system. We have mother or maternal-friendly health systems. Now it's age-friendly. And the 4 M's: what matters, mobility, mentation, and medication. All the things around the Brain Health Initiative, the things we do in the ERAS protocol. Really this strong evidence base, and I would urge you at your hospital to become age-friendly, but at least assessing and looking at ways to improve all of these things, including what matters to the patient. Now, the ASA has produced a perioperative brain health sort of cheat sheet of what people should do, use of a packing list. In other words, do things to bring things in that can orient them. Bring photos. These are things for the patient to do. Have a good idea of a plan for friends to visit. All of these things, and as you can see, it's downloadable on our webpage and really co-branded with the American Geriatric Society. So, in summary, brain health is a huge issue for older adults in the perioperative period. It's potentially reducible, and it's something we as anesthesiologists worldwide can do to help our patients. Thank you.